Good afternoon and welcome to Surviving a Meaningful Use Audit, a complimentary webinar from healthsystemcio.com sponsored by McKesson. Just some housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com. We will be taking questions today, so go ahead at any time. You type them into the lower right-hand corner of your screen, the Q&A box, and leave the default set to all panelists, and we'll take them later in the program, but feel free to send them in as they occur to you. You can download the deck by using the URL on your screen. I will send it out in the chat box, and there's a shortened URL at the bottom of all slides. And we will have an archive available of our event today. It should be ready within 2 business days, and you'll receive an email when it's ready, and a separate registration is required. We have a little change to our itinerary today. I know most of you are expecting Frank DeSanzo of St. Peter's Health System, but Frank unfortunately became unavailable at the last minute, and we've got our good friend Ed Ricks, VP of IS and CIO at Beaufort Memorial Hospital, to step in, and Ed is well-versed in our topic today, so we're looking forward to hearing from him. Then we'll hear from our sponsor, represented by Deborah Bulger, VP of Product Marketing with McKesson. So without further delay, I'm going to turn it over to Ed. Ed, thanks for jumping in today.
Okay, thanks, Anthony. And sadly, I think you're right. I guess I am versed in the topic because we went through an audit a few years ago, and so I'll just spend a few minutes and tell you what our little story was like, and maybe it'll be helpful, and tell you what I learned from that, probably more importantly. So, remember, gosh, I can't believe it's been 4 years ago when we started working on meaningful use, and nobody really knew what we were doing and what we were talking about. And I think, like most people, we started digging into what we had, what our vision was, and kind of our long-term plan as far as an EMR growth and what we're going to end up with. And so we did the gap analysis that everyone else did and tried to line that up with the meaningful use objectives once they became somewhat finalized from CMS, and actually brought in a company to help us with that because I didn't want to just go down by myself, I guess, so to speak, and understand what we were getting into and what the complexity was for some of the objectives, and make sure that we had a good plan in place so we could get everything done before the deadline and actually meet meaningful use. And we were one of the hospitals that I just kind of had a firm belief that we wanted to be able to attest the first year if possible, because who knew what would really happen to the program over time. And I know a lot of people were worried about having to be a stage 2, within another year and a quarter or something, and it just kind of made sense that CMS was going to have to change that ruling, which they eventually did. So that worked out good for us. So we did all the work. We had the hospital committee. We had the project plan, all the effort from the people in IT, and actually it's not even an IT initiative, it's a hospital-wide initiative, and so, it's the physicians and the clinicians and capturing the proper documentation, changing their workflows, sometimes to the detriment of what really made sense, but regardless, we needed to be compliant with the objectives, and we did all that, and we did a test, so our 90-day reporting period for fiscal year 11 was basically the last year of that, or last quarter of that fiscal year, July through September. Went through the process of registering with CMS for meaningful use attestation, did the attestation, type in any numbers you feel like typing in through that process, and hit the send button and felt pretty good about it. Got our money, and this is what our CFO looked like, after we got the first batch of money in from Medicare, and we also went through a Medicaid attestation in our state at the same time. So it was really good. I mean, we felt great. We'd done the hard work. We were doing the right things, I think, from an IT perspective, and more importantly, maybe from a cultural and clinical perspective, and we're able to attest for meaningful use that first year and got the money for it and felt really good about that. And we're not a huge organization. I guess maybe I should have framed ourselves to begin with, but we're about a 200-bed community hospital. We're a private, not-for-profit, independent, one of the few left in that category, in relatively good shape financially. I'd like to think it's because we're well run, but maybe it's just dumb luck too. And to some degree, we have geography on our side because we're literally on the edge of the water on the Atlantic Ocean. So to our east, we have no competition except for fish and sharks. And to the north and south, it's really because of the area around here. We're about an hour away from other cities, and there's some nice tertiary hospitals that we actually refer out to back and forth. But from a competition perspective, we more or less compete with ourselves, and so that's what we work for. So it was good. That money made a difference for us. It didn't offset our entire investment in IT, and I don't think it was ever really intended to do that, but it's still nice to be able to take advantage of it. Throughout that whole process, we understand what the government is like. RAC was just really ramping up, and so we had been prepared for an auditor. We thought we were. We felt like we did all the right things to do the right things, first of all, and be prepared for an audit in case that were to happen. And, we did have that independent gap analysis between all the objectives and what we were doing and what we felt like we had to do and to meet those properly and document properly. And we worked really closely with all of our vendors, really, but we're primarily a Meditech 6.0 customer, although we do have a few other best-of-breed applications that kind of fell into the meaningful use calculations for us. So we worked with them to utilize what they considered the best practices to improve workflow and capture the appropriate documentation, whether it was through the CPOE process with providers capturing things up front or the nursing documentation or whatever it might have been. Just a lot of effort went into that, a lot of working with the clinicians, implementing new workflows where appropriate, and trying to do all the right thing to capture the data that we needed to capture. And as I mentioned, and I don't think any of you folks would disagree with me. Some of those things are great. Some of those objectives were ridiculous. I think it's getting better over time as we refine to stage 2 and stage 3, but still it was like the tail wagging the dog. We were doing a few things because we had to, and I had no better explanation for the clinicians than that. And I hate that. Usually I like to say because it's going to improve the care delivery process, which is really why we're here. And in some cases it really didn't, but regardless, we had to do it. We did use, obviously, certified software and went through that process. We ran the reports that were created by our vendors that were certified so that we captured the appropriate data from the work that we did and sort of thought we were being smart and saving everything, or at least we thought we were saving everything that would be appropriate to validate that we were doing the right thing. Because I feel like, and I think everybody does, that we want to do the right thing, we're going to do it the right way, and we want to be able to show that if we ever had to in anticipation of an audit, which we didn't anticipate, but regardless, we wanted to be ready for it if that need ever came up. So we saved, obviously the vendor contracts, the detailed reports for all the measures that we calculated and attested to, had gone through a high-tech, HIPAA security assessment, which you can do yourself. I'd actually engaged a third party to help with that because, again, I wanted some kind of fresh eyes and perspective and I wanted to make sure we didn't miss anything. Had recommendations on them to mitigate some of our security concerns and had implemented the ones that were reasonable. I mean, it is risk management, and so you can't do everything. I think our original report, again, this was about 4 years ago, had 63 items listed on it, and it's just risk management. So we were just calculating a risk and deciding what made sense to attack from either economic perspective or the best win by implementing either a technology or some kind of administrative control or policy or something like that. But we'd gone through that effort, created a security team, and kept all the documentation for that. So we were very comfortable. We thought we'd done all the right things. We were moving forward. We were starting to plan for stage 2. And we were about a year in to the process, and then all of a sudden one day got a little letter in the mail and an email from some company that almost went unrecognized at the time because it did not come to me originally. It went to someone in our finance department. They didn't understand what it was, threw away the original letter. Luckily, I ended up getting an email a little bit later saying, why haven't you responded? This is important. And it was from a firm called Figliozzi and Company, and they were the external auditors that CMS had hired to perform meaningful use audits. So we'd been randomly selected of that first batch of attestation folks for audits. And I do know now that they're actually doing a lot of kind of prepayment audits. And before, this was all post-payment. So we already had the money, and we had to prove that we'd done the right things, and or they would take money away, essentially. So the submission process with them was very, very interesting, and I believe that they've gotten a lot smarter since then, and certainly we have, and I'll talk about some of the things that we learned through the process, but it was very, very formal, but very much non-personal. So I had no contact with a person. I couldn't even get anyone to answer an email. This was just all email requests to me. There is a secure web portal that you log into for the company to submit information that's the supporting documentation that they ask for. And if you've already gone through an audit, you know this. And if you haven't, essentially, they gave us a list of each of the objectives that we had attested to and I thought what they were looking for support to validate that the information that we submitted, whether it was a numerator and denominator or just sometimes a yes and no, that we had done the right things and could support that and submit that information. And I think that the first round, they ended up giving us 2 weeks to respond. So there was a deadline that I had to submit this information. So for us, not a gigantic hospital. Today we're about 1,500 total employees, about 25 in IT, and we had a few other various people in our Meaningful Use Committee. But as far as going back and gathering information and trying to create new reports if necessary, it's a huge burden. It took an awful lot of effort from just the few people who had the ability to do that here. And a larger organization might have more people, but regardless, it's a lot of effort to capture and gather, collate what you need, and get it sent back in. But we did. So we got all the right information. We thought we totally submitted what would support the fact that we met all the objectives appropriately and that our numerator denominators made sense and why, and submitted that in. And I thought, well, this is really good. So I had a deadline to submit, but clearly they had no deadline to act on that submission. And so a fair amount of time went by before I heard anything back at all. And I don't know if that's good or that's bad. And again, probably the process has changed a little because this is we went through this process late in 2012 calendar year, I guess, just to frame it for you guys. So it was almost a year after we had attested, and it was right at the end of the calendar year when we started the process with them. Finally, about a month later, I got another request back, and this time it seemed silly. So the first time made a lot of sense to me. It just was, here are the objectives. We would like to see this kind of supporting information, and it was in a spreadsheet format, and we submitted that information. So the next request came in, and some of the things didn't even make sense to me. They said, all right, we got the reports that you sent us from your certified software, but we can't use those because they don't have the vendor logo at the top of the report. And I thought, well, that's a ridiculous thing to ask for. You know, the reports came from that vendor. We can show you how we derive the reports going through the menu system, but why would you even consider wasting real estate on a report to have the vendor logo on it? It's totally irrelevant. I can understand the hospital name or the date and the time or something like that, but that was a really big deal to them, and it made no sense to me. So we learned a little bit from that round. We answered, there were other questions on there besides just that we submitted some more information on. But we answered that our reports are not going to have the vendor logo on them. They didn't then, they don't now. The vendors didn't even understand that. You know, and I was talking with Meditech at the time about some of the requests, and we were one of their first customers, at least in our version of the software, that they were working through an audit on. And they were as helpful as they could be, but it was new to them also. And so we gathered more information that they were looking for, and then submitted that. You know, a couple of the things they wanted us to run another report that was newly generated for that same time period. Well, we did that, and we submitted the information, and you guys all understand that the healthcare data is very dynamic data. So what may have been an inpatient account at the end of September 2011 was turned over to an outpatient account the next day because of another CMS request or regulation or something. So, you know, the information could have changed a little bit, and ours did. Some of our numerators and denominators were different by 1 or 2 or 3. It wasn't, you know, like that they were completely off on the numbers, but they were a little bit different when we reran the reports on our live database of information. Perfectly sensible to us in healthcare, but we were working with a true financial audit firm that clearly didn't have any healthcare experience prior to this, or if they did, they were really good at hiding the fact that they did at the time. And so that took further explanation, you know, why all of a sudden are some of your numbers different than what you attested to. And, you know, I tried to explain all this via email or submissions to their portal, just write-ups that we did, that the data was dynamic. And even though that time period was, you know, a static point in time, the information still in the live database could have changed after that. And so this is going to kind of lead into some of the things that we learned here in a moment. But we got another request for more supporting information after the second one. And again, I had a week to respond the second time, and we were sweating it out. We gathered what we thought was appropriate, reviewed it with all the right people here, and engaged our attorneys even to ask for their advice. But all they could apply was common sense, and that was the same thing that we were trying to do. Send in my information, and then weeks go by with no response again from the auditing firm until we get the third request. And the third request was asking for even further detail in a few areas. And one in particular was, in some cases, it's okay that you had 0, for your denominator or numerator on something. One of the cases was in our request to have medical records delivered electronically to the patient. We had a mechanism in place to capture that if the request came through and to show that we fulfilled the obligation within the time frame that was required in the measure. We just didn't have anyone ask in that 90 days, which doesn't surprise me because the public didn't know about meaningful use. It wasn't something we had to advertise to them. People would come in for release of information and go through the traditional mechanism of that. And in some cases, that was electronic releases. But some of the information that they could ask for that we were obligated through the objective and meaningful use, just nobody asked for that in that 90 days. And that's fine. And even in the CMS site and all the facts and everything that you saw from CMS at that point in time and all the opinions that we could get from consultants, clearly it's okay to have 0 because 0 was the number. But they wanted me to prove it was 0. And I don't know how you prove something didn't happen. And that was a very difficult thing to go through. And so that took a few more emails, and at least we were getting email responses, which was very helpful at that point in time. But you can't prove the negative. I could, if it was the other way around, and so my suggestion was you go find the person that you think asked us for it, and then we'll show you that we handled it appropriately, but there was nobody. So finally I was able to sort of navigate through that with the auditors and could suffice with a paragraph that I typed up for them and forwarded on that answered that. And there were a few other things that they'd asked for more information on. One of them that just kept coming back was the one thing that we've all been doing for probably 20 years, I think now, which is the drug-to-drug interaction warnings in your system. And that's something that's been automated forever as far as allergy interactions, drug-to-drug interactions and drug-to-diet interactions, things like that. So kind of a slam dunk, and it's just a yes or no. When you attest, yes, we do it, no, we don't. We obviously attested yes, and as supporting documentation of that, we were able to provide contracts to the third-party vendor that provides the data to us, what the setting was in our software application that shows that it was on and things like that. And that was never enough detail, which I couldn't believe. And so, again, I had 1 week to respond to that third request, sent the information in, and waited for about 3 or 4 weeks again and got another request. And this time it said very clearly, if you're unable to meet the requirements that we're looking for and prove that this was done appropriately, we will take money back. And that finally scared the heck out of me. And I had 4 days to respond. And there were a couple of very minor things, but one thing that specifically is this drug-to-drug interaction checking, that everything I'd submitted wasn't good enough to that point in time. And you've got to understand, I was able to show them there's a dictionary setting in our software, and I suspect each software may work a little bit differently, but essentially it's either on or it's off. So I was able to show that it was on, just a yes flag. I was able to show, and that was at the beginning of our attestation. I was able to show that from the audit of the history of the changes to that dictionary setting, that over the 90-day period, the setting never changed. And I was able to show that it was on at the end of the 90 days, and they said that was still not appropriate proof to show that it was always on for every interaction and every patient. So we went through, and I didn't even know that our system collected this, but there was a huge detailed audit log of every time something triggered an interaction, whether it was drug-to-drug or drug-to-diet or allergies or something like that, which was good. I didn't even honestly know prior to that our system captured that information. And so we were able to download that, and we had thousands and thousands of those over that 90-day period, all date and timestamp, patient-specific, what the interaction was that the system captured. And I thought, man, this is really, really good. And we had sent that in, and that was actually in the third round, sent that information in and said, how can you show any better? I mean, there were dates and times from the very first day and first hour of our reporting period right through to the very last hour of the last day. And the response from the auditors was, this still doesn't prove it was on for every interaction that you had with each patient. And so when I got this fourth request, and that was the primary thing that they were asking for more detail on, I had no idea of what they were looking for. And so I sent a few desperate emails. I said, can I please have a phone call with somebody to just talk about this briefly, because I do not understand what you're looking for, and I'm obviously concerned. And thankfully, very quickly got a response that yes, and I was able to set up a call for the next day, and which was going to give me 2 more days to kind of come up with a response. And I'll tell you, and I got a great person on the phone, very helpful, and I think she was even a little bit embarrassed probably by what was going on. And she said, nobody's been able to support this the way we want it. She wasn't able to tell me exactly what they wanted, and she said, what we're telling people to do is just write up a little paragraph that say your system is unable to create the documentation that we're looking for, and that'll be fine. And I thought, are you kidding me? All this kind of consternation that I've gone through, and I to this day, I have no idea what would have been appropriate proof beyond all those things. But we did it and sent that information in. And I did learn this along the way, is that to some degree you have to think like an auditor. You can't think like a healthcare person. Everything is completely black and white. You've got to understand if the numbers change, prove why. So we had to dig into detail accounts to show that this account went from outpatient to inpatient or whatever the case might have been, and we're able to get through that. And we did eventually get a letter that cleared us for the audit and said that we were fine. Of course, they have 7 years or 10 years or something to come back and audit you again for that same period of time, and clearly any reporting period after that to be prepared for that. But we learned a few things through that process, which is good, and I believe they did also. And like I said, we weren't the only hospital at that time, and there have been hundreds now, so I know that everyone's gotten a little bit smarter. But one thing was, I think in the certification process, the vendors had no idea what the criteria was going to be required of us to show that we were using certified software appropriately, throughout the course of our stay with our patients. And so while they got certified, that certification process had no connection to the audit process. And to me, that's a huge disconnect that doesn't make any sense. I don't think anything has changed there, although there are less companies for the software vendors to get certified through now. I still think that they're certifying to what they understand the standards to be, but not to how people will get audited against those standards. And again, that doesn't make any sense to me, just from a common sense perspective, and it just seemed like a huge industry disconnect. I would say, we learned to sort of question changes from the vendor. Again, early for all the vendors, and a lot of learning that happened from everybody, but, we had some cases where our vendor changed their philosophy on how some of the reports were calculated, whether it came from the data repository or the live data. And so when you reran the reports a year later, it was running it over a different set of data, in addition to the fact that the data was dynamic in each of those things. And so in some cases when we had to rerun reports, they weren't exactly the same for numerator and denominator. Very close, but not exactly the same. And auditors do not like that, and I think we can all understand that. If they're looking at things completely black and white, that's exactly how you have to sort of think about it yourself. And then even though we thought we'd done a nice job in saving documentation and showing that we were doing the right things, and again, we were. Everyone's doing this with the right intentions, and we're also trying to run a healthcare organization and provide safe and effective and efficient care, which we'll try to not get in the way of ourselves sometimes for that. But we'd saved a lot of information, but I learned a lot. This also drove us to actually buy a new tool to help us save the information in a little bit more organized fashion, actually save a static copy of the data for the reporting period, which is great. So if you need to rerun a report, you're running it on that static information. And so what we ended up with was almost like free consultative advice from our vendor. I mean, I understand we purchased this from a vendor, but it wasn't a huge expense. And I know there are a few solutions out there that do something similar. It was an electronic filing cabinet, so we could store things. We were able to sort of track our progress for each measure over time in advance of reporting, which we were doing before, but it was far more manual than what we ended up with. and just most importantly, a place to file all of our documentation that supported each one of the measures, just in case we got audited again. And I expect at some point we will, and I think that's fair. We all want to be held to the standard of the things that we're doing, so I don't have a real concern with that. It just was really painful for us to go through that process the first time. So a lot of lessons learned for us. I hope a few lessons learned for the auditing firm and some of the feedback that they got and CMS got through that. I have talked to a number of people who have been through an audit since then, some people 2 and 3 times, which is just not even nice. But I think the process has gotten a little bit more streamlined and a little bit easier, but I would still recommend save as much supporting information as you can, obviously contracts, obviously reports that were run to generate the information. If you can save the data in a static format, that's a really smart move. And then just the anticipation of silly questions, I think, to some degree, and possibly that's gotten better, but it was a scary thing for us. It worked out fine, and we were able to attest the following 2 years since then, in fact, and just getting ready to knock off our last year of incentive payment attestation, and then, of course, we start to worry about penalty phase stuff. So there's no end in sight. I'm sure there'll still be audits after we're no longer receiving incentives, and I don't know what that's going to really look like, but I think that always being prepared, having a tool that was helpful was a really big deal for us for the second and third year. So, that made a lot of sense, and just some dumb luck, I suppose. But, Anthony, I think that's the end of my little story, and I'm happy to answer questions at the end when we're all done.
Very good, Ed. Thank you so much for the presentation, and hopefully we get some good questions coming in. Now we're going to hear from Deb Bulger with McKesson, who's our sponsor today. So, Deb, thanks for joining us.
Well, and thank you for having me, and Ed, thank you for that presentation. I felt like I was watching a really suspenseful movie as you went through that process, and I was so glad that it ended well. And so thank you for going through that. I think we hope at McKesson that at some point, once you can get through these initial phases of meaningful use and get past the ridiculous and the sublime, as you described, that there will be a shift in quality reporting and how we do that. Today, so much, in addition to meaningful use, so much of the quality reporting is done manually. You have a host of people out collecting data. It's a whole separate business process. You produce reports in a more reactive mode, and those things are a lot of times focused on the regulatory agency or CMS or even sometimes your commercial payer, and your clinicians and your health leaders are secondary. And it makes it really difficult. You're collecting a lot of data and not taking as much action as maybe you could. Very regulatory-centric, very manual, delays in results and things like that. We're hoping that we can start to see a change with the quality e-measures and the output of the meaningful use process, that we'll start to see a shift, that it will be able to use data as a byproduct of patient care. Imagine that we'll be able to have actionable insight, not just reports, but information that helps you change processes. And that we're starting to see a focus on the audience, being the healthcare organization, the leaders, and the patient. And that again, those reports become a byproduct for the regulatory agencies. So the focus is more on improving quality, managing your data well, and helping to change behaviors that improve the quality of those patients. That's our goal, and that's our hope. And when we designed our meaningful use solution, we did that. We built that design with that in mind. And as we think about what's happening next in meaningful use, that we hope that we start seeing the ability to use these single quality e-measures for multiple initiatives within the health environment. In 2015, many of the e-measures that are currently being reported can be used for the inpatient hospital quality report, and that's a report that goes to CMS that helps determine your payment structure for the following year. If we can do that, we can move, automate that process, remove the manual effort, then analytics becomes not just a data collection effort. We can reduce the manual effort. That lowers cost. Organizations are spending upwards of $200,000, $300,000 a year to collect some of the same data that you're already electronically managing in the meaningful use in the quality e-measures. It also lets you shift data collectors to become data-driven analysts and change agents. Many of the folks that collect data are clinicians, very talented people who could be making difference as opposed to collecting data. And then our third hope beyond meaningful use is performance improvement, not just reporting. So if you have the capability for near real-time reporting to measure variance and understand root cause as opposed to waiting to attest or waiting to send data, you have some actionable insights. The integration of that quality data with your financial decision support information is another key area we're seeing hospitals ask us for, and that is the ability, for example, to take that QRDA report file format and load that into your decision support tools. So now you've connected your quality information with your financial information. You can start to ask and answer questions about if we did the right thing for the patient at the right time, which we all try to do, did it make a difference in the outcome? Did it make a difference in the cost? So those are critical areas that we think if we, again, getting beyond the audit process and all of the things that organizations go through is going to be key if we can get to that next generation of quality. So from our perspective, and again, we appreciate the opportunity to sponsor these sessions. We certainly, McKesson has several EMRs. We have our Paragon, our Horizon business, and as well as a number of physician practices, practice management solutions, and practice physician EMRs. But we built our quality e-measure and meaningful use solution to be a module of that EMR so that we could certify as a standalone and certify from both McKesson and non-McKesson EMRs. So we have a few clients who are not McKesson, do not have McKesson EMRs, and they can use our analytics solution to certify that. These solutions are SaaS-based, so it makes it easy to manage product rapidly and try to address the measures as those come out and start to test and model those and provide those measure updates. And I can tell you one of the most common requests or one of the early requests we had was for logos on the reports. And I always thought that was a funny request, and Ed, I certainly now understand why everybody cares about that. We also have a breadth of comparative data with over 400 hospitals or health system or healthcare organizations submitting data to our database. We probably have one of the largest benchmarking databases in the country with clinical quality measures, and it is all de-identified and aggregated so an organization can select the cohorts that you want to compare to your facility. Again, to start focusing on improving outcomes and not just reporting. And then finally, I'll talk a little about our clinical expertise. We do have we host facilitated work groups to review the audit experience with customers like yourself, Ed. And I will tell you, after I've heard you discuss this, it's maybe more of a support group than anything. But we also learn from that, and so your vendors learn from your experiences, and because there are things we didn't know either as we built into that, Ed, you're exactly right. So we facilitate those work groups, share the audit experiences, and then we have a business advisor mentoring program to help organizations look at, one, are there improvements you need to make in your EHR process, or there are opportunities for you to use this data more broadly for performance improvement? And as it becomes more important from an incentive perspective, are there other programs that you could use these same quality e-measures for in order to gain additional incentives or reduce additional penalties? So we hope that we will start to see a lot of changes happen in terms of quality measurement, quality improvement, and the support that we want to be able to offer to the industry as we move forward into this next generation of meaningful use and outcomes analysis. So any information or any questions you have for me, you can certainly contact me. And I think we have opportunities for questions now. So, Anthony, I will turn this back over to you.
Well, thank you very much, Deb. Appreciate it, and appreciate McKesson's support with these events. Okay, now we have time for some Q&A, as Deb mentioned, so please go ahead, send your question in the Q&A box. Leave the default set to all panelists, and we'll get those in front of Ed. Ed, first question, did you receive any questions on the 14th core measure, the security risk assessment? If so, what type of questions?
Yeah, that's a great question. I should have probably covered that better. I definitely did. And again, I thought having the risk assessment and showing that we did it in the appropriate time frame and everything would be proof enough, but it was not. So actually, even in the first round, besides that information, I submitted where one of the recommendations was to actually create a security audit team for the hospital and have it be something that gets reported up to the board, which we did through our compliance committee of the board, and I had some meeting minutes and things like that. So I thought I was in really good shape there and had even submitted the results of the risk assessment. It was something that they'd asked for. But what their next request was, show me receipts where you bought something to fix the top 10 things on the list. And so I had to explain that's not how a risk assessment works. It's all risk management. You can't fix everything. If I mitigate the top 10 risk to something lower, we still have a top 10, and you certainly can't just throw money at things because sometimes it's administrative or policy procedure kinds of things, and you can't afford to do all of the things you'd like to do. I mean, ask any company that's had breaches. It's just impossible. So that took a few back and forth in education, I would say, more for the auditors of this is risk management. It's not, just a black and white thing that say, here's your problem, fix it, and you're good. And so that was an interesting component also.
Oh, just for everyone's knowledge, we do have an upcoming webinar focused specifically on doing a security risk assessment. So keep your eye out for that, or you can go on our website and register for that. Because I know that's a big topic now. Ed, talk a little bit about Stage 2. Are you looking at Stage 2? Are you going to attest to Stage 2? Have you? And anything differently you're doing to prepare for an audit on that?
We're prepared. We are. Our plan is that in a couple of days the year will be over and we'll have met all the objectives for Stage 2. The nice thing is, at least CMS listened this year to all the lobbying folks and everything, and you sort of get a free pass to go back to Stage 1 if you want to, and it gets confusing as to which version of Stage 1, but you have some options in there. So we're doing it. We're preparing the same way. We are saving the information. We're trying to see what we're doing going forward. My guess is that we're actually going to test for Stage 1 again because there's one objective I'm just not happy with, and it's partly our own fault and partly a vendor issue from our portal, but at least we've got the free pass. What I don't like is that for the reporting period for the next fiscal year, as it stands today, it's still the full 365 days reporting, which just means that all of the organizations that CMS acknowledges cannot be ready for Stage 2 this week have to be ready by next week, and that doesn't make any sense to me.
We'll have to see what goes on with that. You mentioned bringing in a third party, and it gave you a lot of confidence and a lot of comfort. Talk about that decision of bringing in a third party. Obviously, cost is an issue. It's a simple ROI exercise. Is what you get worth the money it costs? So just talk about that for folks who are trying to debate whether to bring somebody in.
As it turned out, I think it was for us. To be honest with you, in subsequent years, we have not done it that way. We've worked a little bit differently on trying to understand the changes to the measures and things like that. But for that first gap analysis, it made a lot of sense to us to, try to really correlate each measure with what we're doing in practice here and, what was missing and how could we implement things to be a little bit more successful with it.
Okay. Any questions auditors posed regarding inaccuracies in numerator and denominator data aside from providing zero numerators?
Yeah, definitely, and that's what I was mentioning. When we reran some reports against the live data, some of those figures had changed by just a number or two. I mean, it wasn't off by a factor of 10 or anything. It's just because it was live data and they either no longer did or they might have fallen out of the range of who should be inclusive for that particular measure, and the auditors clearly did not like that. They wanted the reports to look exactly like they looked when I did the submission, and so that was my lesson learned there, was that we're now saving that data and saving the actual reports for each one. So even if we have to rerun something with today's data on it, it's going to be run over that same exact data, and there'll be no confusion there. I was able to explain my way through it and show the detail of some of those accounts that, maybe they rolled from outpatient to inpatient or whatever the case might have been, and that was sufficient, but it still was something that the folks with the auditing firm just didn't understand what hospital information looks like.
At one point, you said you were kind of exasperated and almost begged them to get on the phone. Obviously, that worked and it was effective, and luckily they did it. Just talk about that dynamic, and for any folks out there, when you want to pull that card out and see if it works.
Yeah, hopefully things have changed a little bit, that starts right up front now instead of after I beg, But I suspect that the volume of audits is much higher now, and I don't know if the volume of auditors has increased or not. So that was crazy. I was really at the end of the rope because I didn't know what else to submit for documentation for the particular thing that they were interested in at that time. Because anyone with common sense or looking at what had been submitted could clearly see that we were able to prove that we did what we said we did. So I was lucky that I did get a phone call set up with the right person, and they were very helpful once I got on the phone, and so that was great. Like I said, they almost seemed embarrassed by the fact that they still weren't happy with the submission I'd give for that particular measure. But I think it's just from a lack of understanding on that end, and I still to this day don't know exactly what they would like to have seen different.
At any point, as things got very frustrating, did you, let's say, lose your cool in an email and state something like, "This is ridiculous"? Did you at any point write anything that you later said maybe that wasn't too politically correct?
Believe it or not, no. And I know you know me, so that probably is a surprise. But cause my mouth always gets ahead of itself sometimes. I just can't stop it. So I did say a lot of things in my office and to my colleagues here, but no, I was very appropriate, and they were very appropriate. And so don't misunderstand me. Very professional, and they were helpful when I got them on the phone. It just was hard to get the right person and get the answers I was looking for because I just wanted to submit what they were expecting.
So I think it's safe to say that's a good piece of advice. You can't lose your cool no matter how frustrated you get.
I think for all relationships, that in this world, that's helpful, no matter what you're thinking.
Right.
Now, I didn't show them that picture of the dogs that look like auditors, so probably if I'd have done that earlier, I might have been in bigger trouble. I don't know. Yeah,
well, let's hope it doesn't earn you another audit if they get a hold of it. That'll be on the questionnaire. Please explain this picture. Is this something you think CIOs need to take in hand, or can this be delegated, managing an audit?
Yeah, I think you want to be directly involved as much as possible, and I understand maybe larger systems might be a little bit more complicated, but certainly you've got your experts that know the data and help with the submission process and all the work you've done, but it's a pretty high-level thing. I mean, if you take away your incentive money, that's a big chunk of change, and there could be other ramifications for that. I think that probably everyone's seen the stuff in the news that there's actually been some legal ramifications for at least one system for falsely attesting. So, I think it's something that's profile enough that you want to be directly involved with it.
Right. Now, just as a final question, this is a little tongue-in-cheek because of what you said had happened when you were initially notified. Do you technically recommend throwing the notification in the garbage?
If I knew now what I didn't know then, I probably would have thrown it back away, but, probably not wise to ignore it completely.
Not wise. So that's officially on the record, not wise.
Right,
to throw
that's
it
the
away.
word I go with. Yeah.
Okay. Well, a little humor never killed anybody, right? So I want to, that's about all we had time for today. I again want to thank Ed for jumping in, did a fantastic job as usual. I want to thank Deb and McKesson for supporting the event. As I mentioned, you will receive an email when our archive is ready and a separate registration is required. Regarding the CHIME CHCIO certification, if you hold it and you've asked us to communicate your attendance to CHIME today, we will. If not, please make sure you do so. Attending our webinars gets you one CEU for each event. questions, comments, please contact me, and of course go to our website to see our upcoming schedule, including the security risk assessment event I mentioned and our archives of the past 12 months. So again, I want to thank everyone for joining, and you have a wonderful day.